Hello, everyone, and welcome back to the Free Market Foundation podcast, The Free Marketeers. My name is Chris, board member at the FMF. On today's episode, we'll be talking about all things NHI. We have a bit of an update for you in that field affecting your healthcare potentially going forward. Whether you use public or private facilities, we're going to chat about some recent comments that might shed light on where government is heading with the NHI. And to help us unpack that is the Free Market Foundation Health Policy Unit's chairman, Michael Settas. Mike, thanks very much for being with us once again.
Oh, thanks, Chris. Thanks for having me on. Much appreciated.
No, always a pleasure to get to talk to you and to hear what you think about what's happening coming from government. Maybe you'll tell us this time they're speaking some sense, but something tells me that might not be the case. So to set the stage a bit, last week we heard from the Department of Health's Deputy Director General, Dr. Nicholas Crisp. Some of you might have come across his name in the media. He's featured quite heavily often when discussions happen around NHI. He said that government intends to proceed with the national health insurance proposals, and he outlined how they see NHI being funded. So there were four options that he tabled. Number one, a surcharge on income tax. Number two, a payroll tax. Number three, the removal of the current medical tax credits that members of medical schemes receive. And fourthly, removal of the subsidy that government employees get for belonging to a medical scheme. Mike, what do you think of those four funding options? Does anything in particular jump out, or do you think any of them are particularly viable?
Well, I think, firstly, none of them are new. So those have all been carried through from the Green Paper, which was published in 2011, right through. There were two white papers. So those are the options that always were there. I think in the white paper there was a VAT option, but I see that subsequently they dropped the VAT option. I don't think that would be feasible or viable. But I think just in principle about the whole funding of NHI, regardless of where it comes from, it's been contentious sort of from the get-go. And in my mind, I sort of think of three issues that are concerning. One is the actual, what the public sector expenditure is now currently, which is 4.1% of GDP. Now, the government's sort of constant mantra throughout the policy process is that there's not enough money to provide good healthcare. But if we go and look, I went and had a look at it, there are exactly 50 countries in the world that are classified as upper middle income. And I went and had a look at all their public health expenditure. And ironically, the average across all 51 countries is exactly the same as ours, 4.1% of their GDPs. On the nose, exactly the same. So we compare favorably in terms of public expenditure, but where we compare very badly is in health outcomes. We lag almost at the bottom of the pile of this group of countries, which tells us that it's not the expenditure that's the problem. It's the management of and delivery of public healthcare, which we all know in the public sector is the quality is a problem. But the NHI proposal has been overtly focused around funding. So that's the sort of first point I think to look at, is we're not out of line with our peer countries. The second issue for me is that in the policy process, the government, and even Dr. Crisp in his parliamentary briefing last week, I think it was, all he ever spoke about was that South Africa spends 8.5% of GDP on healthcare. Implying that that's government expenditure, which it's not. Government spends 4.1, as we said, of taxes through taxes they collect. That's 4.1% of the comes from the fiscus, and there is a further 4.4% of expenditure, but that is private expenditure by private citizens on private healthcare, mostly through medical schemes, some out of pocket, small amount through other health insurance products. But the government's constant position has been that this is one pool of money, the 8.5%, that can be utilized for funding healthcare. But it's half of that's not their money; it's private money. It'd be like saying that you can take all the money spent on private security in the country, and we can pull that as a pot together and spend it on police services. But that's not how it works. So that's the second issue I have around the funding aspect. And then I think the last one is that, and this was also again sort of a common theme through the Green Paper and both white papers, is there's sort of a amorphous contradiction around the cost issue. One is And one position very strongly used to be put forward by Dr. Motsoaledi, one of the previous health ministers, and I think he was the architect of NHI, because it came about during his tenure. And, he had often would just disregard costs, saying it's not important, there's nothing we need to worry about. And in one declaration, he stated that it was the wrong approach to look at the costs rather than what NHI will bring to the country, which, maybe in a perfect world is, but we have to look at costs. I mean, we can't say that it's not important. But yet, with that sort of dismissal, what the target is in the green paper and white paper is to achieve public health expenditure through NHI equal to 8.5% of GDP. That's the target. So what they did is they took the public expenditure plus the private, together that's 8.5%, and they've said, okay, now we want that pot of money to run NHI. So it's very much just a shot in the dark, almost a thumbsuck as to a number they come up to. But that's the number they want, and that is going to require massive increases in tax to get to that level. So to me, it's hopelessly unaffordable, and also internationally, it would make us a complete outlier, completely way out to an extreme level in comparison. As I said, the other 50 upper middle income countries spend exactly the same as we do at 4.1%. To 8.5% is only first world countries that get to that level and are able to afford that level sustainably. There's no ways we can sustain that level of expenditure on public health care.
And even then, one can assume a GDP growth rate of between 5 to 8% per year. But even then, if we get a higher growth rate going, we'll get more load shedding, which will again inhibit growth, which will mean lower funding available for NHI. So we're caught in a bit of a trap, I suppose.
Yeah, but I think that it's an important point though, because all of these things are wonderful, but you need a growing economy to sustain it.
Yeah.
And we're not there. Maybe we can touch on that just now, but yeah, it's an important point. I think it's everything stems from it. So yeah.
So moving on a bit to just focus on the Parliament's Health Portfolio Committee, the hearings that they held on the NHI, those ended a few weeks ago, and there's been a wide array of input on the bill from, civil society organizations such as the FMF, or the RR, Sakeliga. I think unions have commented as well. Businesses will have organizations such as Business Leadership South Africa, to just name a few off the top of my head. Do you think that the Health Portfolio Committee or the Department of Health have considered any of these inputs? And I mean, by considered, one should say not just read the Spark Notes version, sort of a quick overview, but actually considered what different organizations would have put in their submissions.
Yeah, so look, I think there were many submissions. I don't quite know the exact number, but I would imagine there must be, maybe 100 or 200. So they ran from, I think it was the end of 2020 right through to just a few weeks ago, as you said. As you know, Chris, we obviously presented to that committee, and it was a bit concerning that some of the views from the Health Portfolio Committee members was still very ideological. It wasn't considering the input that we provided. It was just, if you didn't agree with what the NHI proposals were, is that you must be against healthcare or providing healthcare to the country, which is obviously not sensical. But anyway, that's just sort of a view that I got out of that meeting, which was how ideologically driven it is. But I think just to look at it now, where that committee is, I think there's a lot of work now that committee is going to need to do, and there are a few things around that. I think the important thing to note is what their position is now. They can either, there's sort of three broad directions that can happen. They can either accept the bill as it is and proceed, or they can send it back for revision with their points to say that this is where they have concerns, or they could reject it in its entirety and say not feasible, go back to the drawing board start from point number one, right back to square one. So that's the position they're in. Now, I don't think politically it's feasible that they will reject it. I think the majority of the Health Portfolio Committee is still made up of members of the ruling party, and the ANC will certainly want the NHI as a draw card for elections that are probably about 2 years away for the next national elections. But but in counter to that, what we saw through the Zondo Commission was, understanding that this criticism that, Parliament has been failing in its job in terms of holding the executive to account on either what they're doing or what they're proposing. So I think there's going to be pressure on this committee, especially given the magnitude and the importance of this NHI bill. It's not a small piece of legislation. This is possibly, in my opinion, and I think a few other people have said, it's probably the largest, most financially impactful policy proposal since 1994. So it's a massive proposal, and I think the committee members are going to be under heavy scrutiny on how they assess and review the complexities of the NHI bill. And it's a very complex proposal. It's viability and its sustainability, the possibility of its success. So I think they're going to be under a bit of pressure on that, and I can't see them coming to any conclusions on whichever the direction it goes in. I can't see it happening too quickly. There's a massive amount of information they have to get through. And as I say, because of this focus on, doing their jobs essentially as parliamentarians, they're going to have to provide evidence of, they won't be able to just sort of gloss through the proposals and say, they're going to have to really pay attention to others and have answers to possibly sort of difficult questions, if you like.
You mentioned Zondo again, so and we talked about this in our previous podcast, but I think it bears mentioning again and just repeating. Part of it might have been the second or the third part of his report, but it touched on the negative effects of things like cater deployment and mixing ruling parties, sort of putting the ruling party first over sort of meritocracy and service delivery and that sort of thing. And how, not that the Department of Health or anyone else would feel they have to justify anything to the Chief Justice, but you have a bit of a higher bar now, because his report is one of the first, I think, documents of gravitas and stature to really point to the pernicious effects of cater deployment, and again how the NHI would extend ministerial and bureaucratic power over private healthcare, and what that might incentivize.
Yeah, it is interesting. That's probably just in that sort of vein. Including Zondo. He's obviously. You must be honest. I read the first report and I haven't got around to the further ones. It's they're quite substantial pieces. But the sort of focus on, yes, government has to actually get value for money out of its whatever it purchases, its services or products or whatever. And in that same sort of vein, it's very interesting to see that the Minister of Finance gave exemption to Eskom and to Transnet in terms of the BEE requirements on future tenders that they would do. Now, that's sort of starting to talk about, let's buy from the best product provider regardless of what, the color of their skin is. That starts to work towards we get value. I don't want to take away from the point of view of what's required in terms of transformation in South Africa, and that is an objection that should be it should be something we should be aiming for. But I think BEE largely in its current form, we can say, has failed to really do that, certainly at a broad level. It's enriched a number of the small connected political elites, but I think there can be alternative ways to do that and meet those objectives at the same time.
Even recently, the Minister for Trade, Ibrahim Patel, talked about how resistance to transformation initiatives is stymieing economic hopes. But I don't think the minister takes enough credit, because I would argue that their policies have resulted in a record high unemployment rate, and they've transformed things very well to benefit, those who are politically connected. So Minister Patel should take more credit than I think he maybe wants to. But in any case, we can do another discussion on Minister Patel and South Africa's trade and economic policies. So Mike, to go back to Dr. Crisp, he noted that when, quote, reforms such as the accreditation of public and private providers are complete, the NHI will be ready to deliver NHI benefits. So are there really reforms in place regarding the accreditation of service providers to provide those services?
Yeah, so I think just to emphasize or to clarify, the principle on which NHI is being built is that all providers in the country, both private and public, will be required to deliver the services that the NHI decides, whatever benefit package it eventually comes down to be, which we still don't know. what that is. But certainly the objective is to pull in both public and private and to deliver care. And, I noticed Dr. Chris called that a reform, which is possibly an interesting terminology to refer to it as such, but either way. But before any provider can actually deliver services through the NHI, they would need to go through a clinical accreditation process and meet the minimum standards as set by a current entity in the Department of Health called the Office of Health Standards Compliance. Now, this office has, we can always call this office Clinical Auditor General. So they do audits on things, but not financially. They audit the actual operations of it, from clinical terms to cleanliness, medicine supplies, patient satisfaction, health outcomes, etc., etc. So the office hasn't done any assessments in the private sector to date, although the intention is later that they will do that. But they have, since 2017, been doing assessments of the public sector. Now, and they've produced a few reports. I think they've produced 3, maybe 4 audit reports, which are quite wide-ranging, cover a whole range of metrics. I think there are 13 in total. But each report that has come out has painted a disastrous picture in the public sector. To the extent in all the reports, only 1% of the facilities that they audited, so these are health centres, community centres, clinics, right up to hospitals, the various types of hospitals, 1% qualify, meet the standard that would allow them to then deliver services in NHI. So in other words, 99% of the public sector would not be capable of contracting with the NHI as it currently stands, what is being proposed. So whilst I recognize that Dr. says that those things will have to come about, I don't know how it's going to be possible to get to a point of fixing. That's virtually the entire public sector is now not able at this point in time to work with NHI because they don't meet that clinical standard. So those are questions that haven't been answered. It's almost like they put the cart before the horse in this proposal. They focused heavily around getting more money. As Dr. Crisp's presentation to Parliament was, these are the taxes we're going to raise, this is what we're going to do. But we won't be able to spend the money because we won't have providers who are able to deliver it. So surely they should be focusing on saying, this is how we're going to fix the public sector, and put as much effort as they have into NHI as to saying, let's fix the public sector, because that will fix healthcare, even without NHI. So that's a bit of an oddity to me in terms of this whole process from the get-go, is they didn't focus around fixing. They just fixing healthcare. They just focused on getting more money to fix it. As if somehow magically that'll fix everything. The one concern I have around this though is that will the government do in this situation? Will they do to the health services, to what's happened in the education department? Is it, if you can't meet a certain standard, just keep lowering the bar. So like now in education we have 30% is a pass rate, which to me is like. It's ludicrous to have an education, you probably call it an education system if that is your pass rate. But will they do the same? So that these public service providers can actually get accredited? Because the one thing that we do know is once they are accredited, as Dr. Chris said in his presentation, then services will flow. Or, in my terminology, money will flow. And one of the views on this NHI is it's more been around creating a mechanism by which patronage networks can be furthered. We know that the Department of Health is riddled with corruption. So, I suppose if you take the sort of cynical view, this may just be a position of wanting that money to flow. So do whatever it takes to get that money to flow, even if we have to drop the health standards that have been set by the Office of Health Standards Compliance. So I hope that doesn't happen, but it is a concern.
Yeah, I couldn't agree more. I think that's an easy way to say you're providing universal health coverage if you just make sure that everyone has access to, I don't know, a bottle of Panados every day, but it might not actually be the quality care that they need. But then you can technically say, well, look, the government is providing healthcare to everyone. So that idea of lowering standards.
Yeah, I think, just to the top of my head thought now, I was just thinking, that, what's actually relevant to that, we obviously have had a worsening of quality outcomes, quality of care and outcomes in the public sector for some time. But that is costing government heavily, because the medical malpractice liability that the state faces now is sitting at over 120 billion now, as the last figure came out of Treasury a few months ago. Now, to put it into perspective, I think in 2015 fiscal year, that figure was 28 billion. It's now 120 billion 6 years later, 7 years later maybe. It's growing at a dramatic rate. Now, I mean, once that starts to get to 200, 300 billion, we start looking at a number that technically is like the Eskom debt. It's sufficient to actually potentially affect the solvency of the country. That number is so big. And that all comes from the issue of poor quality care. If we can fix the quality, you fix that problem. So let's hope they don't go down this road of further, lowering that accreditation standard, because that's just going to take that liability and make it an even bigger monster than it already is. So sorry, that was just a quick thought I wanted to pop in there.
I think that's important to keep in mind some of the possible permutations when one considers policy. I mean, Milton Friedman often talked about not just judging a policy or a proposal by its supposed noble intentions, but by its effects. And if we base the NHI on what has come before in terms of lowering of health standards, quality in the public sector, then there is a bit of a precedent, I suppose. To continue with Dr. Crisp, he noted that NHI services would be comprehensive and would be free. But how realistic do you think this is? Now, to try and play devil's advocate, I suppose even he would say, well, I don't mean truly free. It would still have to be paid for by tax revenues and that kind of thing. But yeah, what do you think of that point?
It reminds me of an American comedian. I can't remember his name now, but it was from many years ago. He said he was a comedian, but one of his lines was, I don't make jokes. I just watch the government and report the facts. I'll try and remember who that was, but that kind of statement. And I mean, I'm not going to say that it's Dr. Crisp's statement, because that has been in the policy process from the get-go. He's obviously just repeating it. But that's pure populism. That's the delusional thinking that we can get to that level. Even if government could get the level of funding that they're looking for, that's not going to happen. I mean, to put it in perspective, there's not a single national health system in the world that currently achieves that. In other words, we can give you comprehensive care and it's free. There isn't one health system that does it. It just simply doesn't exist. I mean, if you look at, I'll give you a few examples. If we look at 3 upper middle income countries, so in the same category we spoke about earlier, South Africa is also in an upper middle income category, Brazil, Thailand, and Mexico, who have far better financial metrics across almost every version of South Africa. The unemployment rates nowhere near what ours are. Their tax base is substantially better than ours. And all 3 of those countries have substantial user co-payments in their public health system to try and manage costs, to try and limit the utilization of services. Just the reality of health systems. It's actually an important aspect to have user co-payments, because otherwise utilization runs away with you. You could take a country like South Korea as an example, way wealthier than ours. Their per capita GDP is nearly 5 times ours. Their tax base is 3.5 times ours proportionately. The unemployment is less than 4%. So we're talking about a country with a vastly different financial position to ours. I mean, we know the miracle of South Korea has been well documented, fantastic growth over the past years. And they do have a comprehensive national health system. It's funded through a variety of sources. The majority of the funding comes from the payroll tax, which is shared between employer and employee. It sort of ranges from about, I think, 5.5% to 8% of payroll. Now, this is one of the options that Dr. Crisp highlighted, in his talk. A payroll tax could be the one option. So that's how most of the funding for the South Korean system comes from. But if you look at that system, in-hospital services in the health system attracted 10 to 20% co-payment that the patient has to fund. Okay, now that's in-hospital services, which are typically much more expensive than out of hospital. So 10 to 20% is not exactly a small amount of money that would have to be paid. On outpatient care, the co-payments are even bigger. They range from about 30 to 50% of costs. So, just as an example, if you went to the dentist, you'd have to pay possibly half the costs of that treatment. So, and in the South Korean example, 80% of citizens buy private insurance to cover these co-payments that they're liable for when they use the national system. So if you have a look at total expenditure in South Africa, in South Korea, getting myself mixed up there, but the public expenditure split almost 50-50 between private and public because of that. So a country as wealthy as South Korea, comparatively to us, cannot achieve free healthcare, free comprehensive. How on earth do we propose that we're going to do? We can even look at Britain, NHS. I mean, it's often heralded, it's touted as the bastion of national health systems, and arguably maybe deservedly so. But even if we look at that now, as it stands today, of total health expenditure in Britain, nearly 1/4 is private expenditure, either out of pocket or on private insurance, which provides a variety of things. Almost 1/4. So I think it's around 22%. But that's a substantial note to say that not even wealthy countries, relatively like Britain, with a very similar health system, the NHS kind of is similar to what the NHI is proposing, although they still are. NHS has evolved quite differently to what NHI is being proposed as, but nonetheless, it's still it's a complementary system, is that you can't opt out of it like NHI is being proposed as well. But I'm saying even there, in a much wealthier country, nearly 1/4 of expenditure is not funded through the national health system. It has to be funded by patients on an out-pocket basis. So I would say to Dr. Chris that, maybe they should rethink about selling that, because, really it's never going to happen. We'd be a world first if it did.
Yeah, well, they talk about South African exceptionalism, so that would be another one to add to the list. Yeah. He went on to note that once the NHI is up and running, medical schemes would not be permitted to cover services that the NHI covers. So effectively, this means that citizens currently on medical schemes will be forced to use the NHI. Does this make financial sense for the NHI to assume responsibility for the healthcare of every citizen? I mean, surely if someone can afford to go to their own private healthcare provider and pay for that alleviates some pressure from the government. And I think in our view, in the FMF's view, government should, if possible, try and focus at least on providing quality services for those low-income citizens who really can't afford, anything on their own.
Because it makes no sense for any health system, national health system, to exclude people willing to purchase private care, because those willing to purchase their own private care take themselves out of relying on the public system. So effectively, it improves the public sector budget, because you're dividing a fixed budget, through by less people. So, but to put it in some perspective, in technical terms, it's what is known as a complementary single payer system. So complementary meaning that the private sector can only insure services outside of what the national system provides. Britain is also a complementary system, but I think what's important to look at is they're one of only 5 countries in the world that have built a complementary single payer system, and that's because it's the most expensive system of all, because you assume responsibility for absolutely everybody. So again, it makes no financial sense to us to go down that road. We're not a wealthy country. We can't afford. Britain was able to do it. Canada did it as well. But all the countries of the 5 that have done it, they're all much wealthier than us. And they still have their problems. I mean, Britain's NHS is by no means ideal. It still has long waiting periods. Canada's even worse. Many people are denied care. So even rich countries struggle in these structures. So we are going to struggle massively in a structure like this. The better financial proposal for us is to say, get the private sector fixed. The private sector is expensive. I mean, let's make no two mistakes about it. It has its own problems. But it does fortunately still provides good quality care. So, but unfortunately, it's limited to only, relatively wealthier people in South Africa because of its high cost. So that's the sort of failing of the private sector. But interestingly enough, the groundwork to fix the private sector is all there. It's been done. It was done through the health market inquiry, which was run through the Competition Commission over a 6-year period. They did extensive analyses that invited all stakeholders to input. They did expert overview of data. So the actual blueprint to fix the private sector is there. So, you know, the private sector currently has about 9 million people in it. So it's about 15% of the population. But imagine if that 9 million was 20 million. The public sector budget would look, you know, substantially better than what it looks now, because you'd be looking after far less people. So that would be a far more realistic path to go, and would simultaneously improve the public sector budget, which then would allow them to deliver better care, higher levels of care. Remember that with healthcare, it's aspirational. Nobody who can afford private healthcare doesn't buy private healthcare. It's an aspirational aspect. Everyone wants the best for them, for their family, for their, you know. There's nowhere in the world anyone doesn't do that, unless, you know, maybe a small percentage of people who might have an opinion about it. But it's worldwide. It's, you know, if you can buy private care, they will. If you take countries like Australia, much wealthier than us, first world country, they provide tax incentives for their citizens to purchase private care, to take them out of the public system. They're doing that because of cost pressures. I mean, you know, how do we think we're going to finance comprehensive care if Australia can't? You know, so I mean, it's not the right route to go. But the NHI has been focused on that ideology from the get-go. So I think, you know, if they stick to the ideology, there's not going to change. That's been sort of a fundamental from the beginning. But I do think there'll be challenges on that, because I think, you know, a couple of legal aspects, legal people I've spoken to have said that's contradicting Section 27 of the Constitution, because you're actually denying, you're actually removing access to care for people willing to pay for it themselves. So I think that will come under challenge if NHI pushes forward as it is.
Oh, there's various ways of fighting back, and I'm sure that people are getting their arguments and precedent ready in case it does have to go to court. So yeah, it's not just because Dr. Crisp announces NHI is now operational doesn't mean it's the end of the story.
Yeah, no, I don't think so. Look, I think what was also interesting about that is in the public hearings to the Health Portfolio Committee, I was quite pleased to see. I think it was sort of towards the end of the hearings, that it might have been sort of January, February this year. I know the likes of, say, Discovery, who are the biggest medical scheme in the country. Yes. In their proposal, they didn't just sort of highlight their concerns. They actually put forward an alternative proposal saying this is how we could see it working. I think it was one of the hospital groups did it as well, one of the private hospital groups. So it's good to see that kind of engagement with the Portfolio Committee, that it's not just to say, you know, we're happy with as things are, because I think a lot of accusation against the private sector is that, you know, private sector just wants to keep the status quo because it works for, you know, and then so the likes of a Discovery would easily take that kind of flack because, you know, they're a very successful financial services group, and they, you know, obviously make lots of money, but it's easy then to target them, to say you just want to keep it this way because it suits you. But they actually came along and put some alternatives on the table to say we think it could work like this, and I think that sort of engagement is constructive and valuable. And I think, you know, I was pleased to see that. And I hope the Health Portfolio Committee and the assessments looks at those sorts of things. You know, I think we also when we presented last year, I think it was May, June, we also put an alternative proposal in the table. So this is how we think things could work. So let's hope that Portfolio Committee actually does look at those things.
Yeah, absolutely. Before we get to our final question, I thought I would add in an additional one just on what I read this morning, an interesting op-ed from Melanie Verwoerd on News 24, and the headline is "The NHI get rid of corruption and maladministration before asking me for more tax." Now, Mike, I haven't read through the article, so I'm not sure what specific recommendations she makes, but if you were writing a similar op-ed in terms of getting rid of the maladministration, what do you think in terms of low-hanging fruit stands out? Is it a case of maybe devolving more power to the provinces, or sort of other things around getting a bit rid of sort of wastage and corruption, or at least disincentivizing those things?
I haven't read the article either, but I'll definitely go have a look after the session. Yeah, look, it's a valid point. I think many people have raised that, you know, we have in the Department of Health, we have very widespread corruption that has basically disabled its ability to deliver quality care.
Right.
We know the aspects of cadre deployment, which, the Department of Health, although Zondo didn't specifically look at the Department of Health, there's no reason to believe that it's not as big a problem there as it is, as we've uncovered it. In fact, there is evidence we can say that the Office of Health Standards Compliance, where I mentioned earlier, so two of the 13 measures that they measure on how the health establishments that they do an audit on is governance and operational management. And those, out of the 13 scores, those are the two lowest across the board. So in other words, you're looking at governance structures that have been, disabled, and that's required if you want to have patronage networks, because good governance would avert that. And operational management means you just don't have the skills there to say, hospital manager as an example. It's a very skilled job. That it's not a you don't just have managerial skills and become a hospital manager. You have to really know what you're doing. It's certainly if you were to say to me, "Well, I run a hospital," I'd be terrified because I wouldn't have a vaguest idea where to start. So it's a difficult job. It's a job that requires skill and experience. It doesn't necessarily have to be a doctor, but it does require some very particular skills. So that shows clearly in that report that there's a lot that can be done. If we fix those aspects, I think the quality of care within the current public sector budget could be dramatically improved by fixing the issues in the management, the deployment of people, the correct people. I've spoken to certain managers in public sector, and one of the things that strikes as quite a common complaint is that they can't, for many of the unionized employees in the Department of Health, they can't be disciplined or brought to book around, shortcomings in their deliveries because the unions threaten the management. So they just back off and they do nothing. So you've got people who are incompetent, just like being allowed to carry on without any kind of thing. So, any kind of corrective action. So there's no question that if you're in an environment like that, there's massive scope for improvement. A good example would be to look at the Western Cape. So we'll take a punt for the DA. We'll put in a punt for them. Not that we're aligned to political parties, but when you look at it, the evidence is quite clear. The medical malpractice liability in the Western Cape is negligible. It's a couple of million. It might be something like I can't remember the exact number, but as a percentage of their budget, it's minuscule. It's something like 1% or 2%, I think. Now, if you contrast that with the Eastern Cape, the eastern neighbour, which has roughly the same population size as the Western Cape, and they have roughly the same public health budget. Can't remember exactly, but they're not too far apart from each other. The Eastern Cape's medical malpractice liability is greater than the entire annual budget. It's 120% of the entire annual health budget. The Western Cape's is 2%. Let's call it 2%. It's around about this. Now, those are it's a massive contrast that you see in terms of the quality of care that's being delivered there. Because the Western Cape has managed to avert the pernicious factors that reduce the quality of care. I'm not to say that they're perfect in what they do, but the evidence is clear that it's chalk and cheese. It's two different planets that are between those two. I think the journalist you mentioned, Melanie, I think she's right. Fix that, and then come ask me for taxes. And I think it raises an interesting point as well. I mean, if you had an ethical, capable state, let's just talk the public health sector, we might find that our delivery of care is so good that actually it's working fine. We wouldn't need to do it. We wouldn't need an NHI. We wouldn't need extra money because we'd be providing a good level of quality. But we'll never know that unless you actually fix it and get to that point first. The government's saying to us, we want a lot more money, a whole lot more, and then we'll give you better healthcare. Rather should be the other way around. Fix the healthcare system first and then come ask us for more. I think that would be the better way around.
Oh, the burden of proof idea that rests on government to prove and show that they can maybe fix some things before taking, and maybe they have Bitcoin or something that they can use to pay for the NHI service.
Yeah, it's like if you go and ask your boss for a raise, I mean, you don't ask him if you've been starving off and taken sick leave in the last 2 months. So you go because you've done a good job or something, and you'd like to get it. But it's a strange psychology. But anyway,
our final point for today, sort of the final discussion topic. The NHI proposal has been on the table for many years. I mean, at the beginning, you talked about various forms of papers and policy positions that have been formulated. And obviously, we've got to get to a point where there is a bill and it could become legislation. So do you think that this NHI will come about as is, or do you think it'll change substantially before being implemented? And I think there your point around the 2024 elections is very apt, because government will want to sell something. I mean, yeah, there's a view that the ruling party will be below 50%, possibly even low 40s in the general elections of 2024. So they'll need to find every possible selling point, as it were. And you can't just ride on President Ramaphosa's popularity. There will have to be other promises in those elections.
I think they need a lot of promises. Look, I think to be fair around this whole point is that using healthcare as a political tool in electioneering is it's not unique to South Africa. I mean, it's worldwide. It's in fact one of the top 3, probably along with economic growth, education, healthcare. Those are the sort of ones that are always there. So it's obvious that any party will use health proposals as a tool. So the ANC will definitely use that in the upcoming election. As well, I say I don't think this bill will be rejected, because otherwise that whole proposal then fails. But it isn't obviously in the form of a bill now, so it was passed by cabinet. Now it would require passing by Parliament, and then obviously it would go to the National Council of Provinces as well. But the barriers to where it is. So in other words, it's progressed quite a bit, although it's been slow. I mean, you have to understand that NHI was official policy in 2008. So we're now looking 14 years down the line. It's taken 14 years to get to a bill. Well, I'm actually a bit less, because the bill was passed 2 years ago, or 2019, I think 3 years ago. So it took a long time to get there. So it is in the form of a bill, which potentially, if it got passed, all the green ticks, it would then become legislation. But there are numerous barriers to implementing. I mean, the obvious one is money. The additional funding, there's the government's looking at the 8.5% of GDP that we spoke about. I mean, this would require raising taxes equivalent to 3.2% of GDP in the current numbers, which is a figure of about 175 billion rand a year. So that's more than a 10% increase in total tax income. As we saw from SARS recently, with the Commissioner, Edward Kiswater, said, we've had a good year, thankfully. But what NHI is saying, we want to collect 10% more in taxes. Now, that represents a massive increase in tax levels. It would be, I think, something like a 35%, 40% increase in personal taxes if it all came from there. So I think from the point of view, the Minister of Finance has been pretty adamant that there are no more bailouts for SOEs. I think he's resisted the temptation of the basic income grant, more expenditure there. So I don't know that the Department of Health is going to be very successful in actually getting Treasury and the Minister of Finance to agree on certainly that level of additional taxes. And that was the number that Dr. Chris mentioned in his parliamentary briefing. He said 8.4, but the numbers in the green papers and the white papers has been 8.5, so it's kind of pretty close to that number. But again, you also talk about it as well, is the NHI bill has sort of put forward this, it's saying it's not a money bill, but it's talking about the appropriation of funds. Now that rests squarely within the finance ministry with Treasury. And if you think about it, if there were more taxes raised, where would Treasury want to spend it? Remember, they're the ones who decide on the appropriation of the funds. So I'm not necessarily sure that it would be top priority for Treasury to say, yeah, we're going to allocate it to NHI. There might be, if we take things like grants are probably likely to grow in volume in South Africa because of where the economy is. That's going to require funding.
And even on that last point, sorry, but I mean, last week, Moodys, they changed our credit rating outlook from, I think, negative to stable at least. And they'll look for stuff like, they gave the government credit for now sort of consolidating government spending on a better trajectory. So they'll look definitely for things like big ticket items like a nationalized health insurance.
Yeah, no, look, I agree. I mean, I think NHI has been flagged before by the ratings agencies as being a major concern in terms of costs. So yeah, I think cost is certainly the biggest factor, but there are various other things as well that are important to look at. I mean, we've spoken about what disarray the public sector is. Now, I mean, the NHI proposal is quite complex in what it's requiring, quite a transformation of every facility in the public sector is going to have to become its own legal entity in order to contract with the NHI. That's quite a process to do that. It takes several years to get that sorted out because they're not juristic entities at the moment, so they can't contract. It's just one sort of aspect around it. And then also throughout the policy process on NHI, there's been a complete absence of any technical feasibility analysis to understand the many technical implications of what's being proposed and how likely it is that the NHI will operate. The consideration is to take the public and private sector and simultaneously collapse them into one entity, being the NHI. The ramifications of that are enormous. So it means there's a massive implementation risk to that. And I'm not sure that, in fact, I'm confident that they're just not up to the task in terms of this. Of what's required of that. So I think there are a lot of barriers to getting it through. There are other things that haven't even sort of featured anywhere in the policy process. I mean, one thing that should be an important aspect around any health policy is, assessment of where your population is going. South Africa, we're adding 1 million people to the population every year. That's our growth rate. We're sitting at about 1.6. I mean, female fertility rate in South Africa is still sitting at about 2.5. So it's very much on the high end. Our population is growing because NHI is tax funded. I mean, the more people we bring in, it's simply increasing the liability of the state. So unless we can get, as I said, we spoke about it earlier, unless you can get the economic growth to exceed that population growth, in per capita terms, we're going backwards in wealth. And then you've got a proposal like this, which is putting massive liability on the state. It's just going to get worse if those metrics are if they're not diverging. So unless our growth rate gets above our population growth rate, NHI is just going to become a more and more expensive entity to run over time. And that sort of thinking hasn't even featured anywhere in the policy process. And I think it's concerning that they haven't done it. But so I think, in short, to your last question, Chris, I think there are a lot of barriers to getting this. Potentially, I think, especially in the private sector, a lot of businesses will be imperiled with this proposal because the private hospital groups will be massively disrupted. The big medical schemes and the administration companies that sit behind them. So I think there's potential for legal challenge, assuming that more sort of diplomatic process of engagement doesn't work. The last resort will be going to the courts, and I think there'll be a lot of ammunition to challenge this proposal because of the weakness of the policy process. So yeah, there's a lot of barriers to this. So I'm not overly concerned about it, coming soon, but I'm just worried that it doesn't get altered and modified into something more workable. That can actually be implemented, because in the interim, what's happening is nothing's happening, and the public sector is in disarray, as we know, and there's no focus around fixing those issues. So that I think is the concern, is that this policy sits in limbo, and nothing's happening anyway in terms of improving health outcomes.
Yeah, I think that's a pretty comprehensive sort of conclusion on which to end, and I think it's always useful to be as informed as possible in terms of what's happening in South Africa's policy space. So I think this has been a very good discussion around the latest developments with the NHI. So Mike, thank you very much for your time today.
Yeah, thanks for having me on. It's always good to chat and share views. Thank you very much, Chris.
To the viewers and listeners, we hope that you enjoyed the episode and found it useful. If you haven't yet, please like the video before you leave, and also remember to subscribe to the FMF's YouTube channel. We will be sharing more episodes coming up soon, so keep an eye out for those. Until next time, take care, and we'll chat to all of you again very soon. Bye-bye.